Welcome to ECRI Institute's Evaluation Lab. My name is Jason Launders and I am the Director of the Evaluation Program we run here at ECRI. Today we are addressing renal therapy in the case of COVID-19 patients, and I am joined by Dr. John Kellum, who is the Professor of Critical Care Medicine at the University of Pittsburgh and the Director of the Center for Critical Care Nephrology, and he's going to bring his expertise to us. I also have with me Dr. Andrew Furman, who is the Executive Director of Clinical Excellence here at ECRI. He has 18 years of emergency room experience as a physician and brings that perspective to us. And also remotely, we have my colleague who is the Executive Director of the Supply Guide product here at ECRI, Tim Brown, who is going to talk to us about what we're seeing in the supply side. Before we get started, we're going to ask you two very simple poll questions. The first question is, are you seeing more demand for renal therapy in the ICU currently? And the second question is, are you seeing a supply shortage for dialysis supplies? And while you're answering that, just to explain how we're going to work, we're going to have a conversation between these experts. And following that, we will go to a question and answer session where it's your opportunity to ask whatever relevant question you may have while we're here, and we'll do our best to answer it. In the meantime, this recording will be made available on our COVID-19 Resource Center in about 24 hours, once we've got it sorted out. And we will be putting any other resources on that as well. So without waiting much longer, I'll hand over to Dr. Furman.
Thanks, Jason. We've been receiving a lot of questions regarding COVID-19 kidney-related concerns, and you've met many of our internal experts and seen the variety of experiences and backgrounds that we've had with our experts. And then there are times when at ECRI we'll reach out to subject matter experts that are external to our both physical and virtual walls these days. So very happy to have Dr. Kellum with us today. I think we'll start, though, with just a quick question to Tim regarding the current supply situation.
Thanks, Andy. So related to this category, we have been closely monitoring product availability and price trends related to dialysis tubing, dialyzers, and dialysates. And overall, as compared to other COVID-related supplies, we've seen healthy inventory within each of these respective categories. However, there may be variability based off of location. In addition, when assessing price trends in each of the related categories, we have not really seen any spikes. They have remained relatively flat. Right now, dialysis tubing is running about $2.80. Dialyzers are running about $9.18. And dialysates are running at about $1.90. And those are all each prices. Back to you, Andy.
John, Dr. Kellum, thoughts on what Tim just said?
Sounds like I need to realign my investment strategy because dialysis is running about 100 times more expensive than oil. Is the first thing I would note. But on a more serious note, I think that feels about right. I think across the AKI landscape, if you will, we're not seeing a overall shortage or instability, but we are seeing and hearing about some regional problems, and I think it's worth reflecting on that a little bit. If you're a community hospital where you treat, we'll say in a given year, you treat 1,000 patients with sepsis, and you put half of those patients in the ICU and half of those patients develop AKI, you're going to have about 20 or 30 cases where you might require acute dialysis. And that's what you'll have. And if you see twice that number in a single month, you're going to run into trouble. And I think that that's a very different scenario, for example, to a large tertiary care hospital like the one that I work in, where you're seeing a lot of AKI and dialysis requirements on a routine basis from, say, elective cardiac surgery. And you're not doing elective cardiac surgery right now, or you're doing very little of it. And therefore, the increased flux of COVID-19 patients isn't really having much of an impact because you have all this excess capacity. And so I think there are very different scenarios that can play out across different centers depending on what they normally see.
Okay, and how is COVID-19 comparable to typical sepsis or viral pneumonia?
Yeah, I think that's an excellent question. And I think initially, I think we were thinking of COVID-19 as more of a viral pneumonia, like seasonal flu or H1N1. But we're actually finding it to be a lot more like bacterial sepsis, in the sense that you do see at least a fraction of patients developing multi-system organ failure. Now, there are some really important differences. For one of the most important is that these patients don't tend to present with shock. They often present with relatively single organ failure initially. They have respiratory failure without much else going on. You do see a fairly high amount of mild AKI early on. And I would say that that often resolves with treatment of their hypoxemia and gives you the impression that it's a hypoxic mediated response. And in many patients, just an early stabilization of their oxygen gets them through, and their AKI resolves, and it doesn't become a problem. In the segment of patients whose AKI doesn't resolve, though, a good number of those patients, just like in bacterial infection, will go on to need renal replacement therapy. And those are the patients that a week later or 10 days later, will be adding to the numbers of patients that you then worry about in terms of having enough equipment.
Are there ways to predict who those patients will be?
Yeah, so again, I think the data is still relatively fresh. And therefore, one wants to still be a little bit cautious about its interpretation. But the early indications we have are that the same kind of risk factors that apply to sepsis-associated AKI apply here as well. So, if you're 20 years old and have normal heart and liver function, your risk of AKI is relatively low. If you're 70 years old and you get hospitalized and in the ICU with COVID and you have diabetes and heart failure, then your risk is exceedingly high. So the risk factors go along the same lines: age, underlying comorbidities, particularly chronic kidney disease, chronic liver disease, diabetes, are all significant risk factors for AKI.
Okay. And so as much as there's still a lot of questions that are unanswered, it feels like there's an opportunity to plan, because there are some predictable expectations with this illness. Could you comment about just planning and what you might do maybe as a community hospital versus the academic center?
Yeah, I think it flows from the discussion we just had, which is that if you can really better understand your AKI rates within your COVID patients, then you can much better predict who's going to develop a requirement for dialysis and the numbers that will look like. So, for example, if you're finding that 20-25% of your hospitalized patients are developing AKI, then you'll sort of know that somewhere between 5 and 15% of your overall hospitalized COVID patients are going to wind up on dialysis. Now that's a high rate, and if you're seeing that, one of the things you need to be asking yourselves is, what's my plan as the surge gets to this? It tends to be a week to 10 days, sometimes even 2 weeks late relative to admission, where patients wind up progressing to dialysis. Now, many patients may progress sooner, but on average, it doesn't tend to be something that happens in the first few days of hospitalization. So I think that there is an opportunity, and I think the opportunity begins with really understanding your AKI rates within your COVID patients.
Okay, and then would you say there's regionalization opportunity, with hospitals and systems?
Yeah, and again, that it becomes easier if you can have a better handle on what the rates are likely to be. So if you can say to your neighbor hospital, I'm expecting this amount of dialysis requirement, next week, then it becomes much less of a panicked type scenario. So I think to break that down, I think there are a variety of different potential vulnerabilities. So, if you're a hospital that has 2 CRT machines, if you have 3 patients, you're having a shortage, and what's your strategy for dealing with that? If you have a hospital that has a dozen CRT machines, but you may not have staff to manage all the patients you expect to have, there's a different sort of strategy, to deal with that. If you have enough machines, but you're concerned about the amount of dialysate that you may have, or renal replacement fluid that you may have, there are some strategies that we can utilize in those patients, such as being more conservative about the dose of dialysis that we use. Oftentimes, we don't need it quite as high a dose, particularly several days into therapy, that we need for patients acutely. So there are some opportunities there. If our machines are in shortage, you can consider shift therapy, so that a patient is on therapy for less than 24 hours, 12 hours or even 8 hours, such that the machine can be cleaned and used for another patient. That's less ideal. Certainly, that's why we have continuous therapy, but it is an option when you're really your back is against the wall. So having a surge plan that's tailored to your vulnerabilities, whether it's machines or personnel or fluid, I think becomes very important.
And I'll just emphasize that point too. We did a prior webcast regarding ventilators. The ask was, we need 30,000 ventilators and we need them now. But that's such a much more complex problem. So can you just reiterate the personnel involved here? Who can actually do this, even if you had all the equipment and supplies?
Yeah, so it's a great question. So it really, again, depends on sort of how you're set up. There are hospitals that don't do a lot of this therapy, and therefore it's all sort of done by specialty nurses in the dialysis unit that go potentially to the ICU. The majority of hospitals have ICU nurses that are doing this, but not all ICU nurses are trained, to do this. And, is there an opportunity to do some cohorting of patients such that it's easier? And then there becomes all kinds of logistical concerns about how you accomplish renal replacement therapy in a COVID isolation type setup. And we probably don't have time to go into that in any great detail, but certainly it becomes much harder when you have single rooms which are in isolation, as opposed to a big unit with several patients. And so some cohorting really does have a big impact on how you deliver these services.
And every room isn't created equal with renal replacement therapy, correct?
Well, that's also true. And there are other things to consider. So, for example, there is the capability of certain dialysis machines for continuous therapy to drain into the commode, or to drain without having it to drain into a bag that then has to be replaced. A drainage bag that has to be replaced every so often, putting staff into the room commonly, et cetera, et cetera. So there are strategies that could be considered. There are some centers that are delivering renal replacement therapy with the machine actually outside the room and extension tubing to the patient. Now, we don't recommend that, but there are, because simply it's untested in terms of extension tubing, et cetera. But, there are different ways that people might want to address this issue in the room that they're having to, if your negative pressure room, is small and has an ante room where a dialysis machine could be placed with lines running to the patient, maybe that is a good strategy.
Yeah, it just emphasizes your point about planning and having a strategy for how you're going to navigate through this. Have you seen anything particular with medications leading to kidney injury?
Not so much, but I do think it's worth emphasizing that there are certain things about this virus that do potentially lead to concern for the kidney, apart from just the fact that we're seeing an infection that causes a huge inflammatory response, which can injure the kidney. There is the situation where these patients can be febrile and severely febrile for days on end, and that does a couple of things. One is that really volume depletes the patient. And so seeing patients much more dehydrated than they might be with other forms of sepsis is important to remember. The second is that it's hard, and I can say this as a clinician. I was in the ICU last week. It's really hard to look at a patient who's febrile to 40 for days on end without covering them with antibiotics, even though you know that you're not getting any culture data back and you're just concerned. And so I think that there are patients that receive antibiotics, in some reports 40 to 60% of patients. And with that comes the potential nephrotoxicity of agents like vancomycin or Heptazo, et cetera. The other is I have seen at least one case where kidney injury was probably attributed in part to the use of a non-steroidal in a patient, who was initially outside the ICU, who just had severe fever, and the only way it could be brought down was the combination of acetaminophen and ibuprofen, and they received a non-steroidal, and that probably, despite the fact that non-steroidals are on average very, very well tolerated, this probably contributed to AKI in this particular case.
Makes sense. And you mentioned inflammation, so I'll just pivot a little bit to cytokine storm, a phrase a lot of people are hearing now, and it feels commonplace as I interact with folks. Can you tell us a little bit about that and maybe possibilities to fix that?
Yeah, so I think that's right. I think, unfortunately, it's a bit of an ICU jargon, amongst the sepsis community. I don't know, Andy, do people use that in the emergency room too?
Not quite as much, no.
But it's a kind of a vague term. What does it really mean? There's a particular scenario, a particular phenotype, a particular syndrome, which can happen in viral infection. So in kids, we have these patients getting Kawasaki's disease, and that's something with viruses in kids. But in both kids and adults, we do see patients developing macrophage activation syndrome or secondary HLH. And this syndrome is rare, but again, if you're seeing hundreds of patients with COVID, you are going to see a few patients like this where they not only have very high inflammation, but they can't turn it off, and their natural killer cell function is impaired, and they just can't get out of this inflammation. Now, for anyone listening who's interested in understanding this better, there's an enormous literature on macrophage activation syndrome and HLH outside of COVID, and we don't have the best knowledge as to how it applies to COVID, but we do know that some of the cardinal features like high ferritin levels, high D-dimers, hepatosplenomegaly, actually a low white blood cell count or pancytopenia, are all sort of cardinal features of this kind of syndrome. And it has a very specific therapy, which involves high-dose steroids and even drugs like anakinra, et cetera, that can be used. There's also some question as to whether certain types of blood purification could be useful in this setting that can be targeted specifically to this population. And so, for example, several sorbents that that can be used, and one of those is Cytosorb, for example, which recently received kind of the emergency approval for use in this setting. And so there is some interest in potentially using those therapies for a specific subgroup of patients that have this kind of cytokine storm.
A little too early, though, to know whether that will work?
Well, I think the problem is we may never have good enough data because the proportion of patients who would sort of qualify will still be relatively low. And so we'll wind up saying things like, well, it looked like it really did or didn't work in these patients, but we're probably never going to have, hard statistical evidence that it was effective. But I think there are efforts certainly ongoing to try to study this in randomized trials, so we'll have a better understanding.
Great. And maybe we can just step back a bit, and think, what is your general approach to managing, a COVID-19 patient with developing acute kidney injury?
Well, that's a great question. We could spend an hour on that just in and of itself. And like other forms of AKI, I think it's important to realize that this is not a single disease, right? So, you can come in with an elevated serum creatinine, low urine output with COVID because you've been at home for a week dehydrating yourself because you're not eating and drinking and you have a fever of 40. Mm-hmm. That's a very different scenario than a patient who's developing AKI in the setting of, good filling pressures, good, hydration status, but very severe inflammation. There also are concerns that the virus can directly infect renal tubular epithelial cells because the entry to the cells, the epithelial cells, involves the ACE2 receptor, which is very heavily expressed on renal tubular epithelial cells, as well as the gut epithelium. And so patients coming in with diarrhea and AKI, there's some concern that, this might be a systemic illness that's involving multiple epithelial, the lung, the GI tract, and the kidney. And that's a very different scenario than the other two. And so, and then if you want sort of a third one in there, we know that some proportion of these patients develop cardiac involvement and can have either cardiac sudden death or very low ejection fractions and develop sort of a cardiorenal syndrome as part of their course. Now, I think what differentiates some of these patients is the time course. Patients who present with AKI are frequently patients who the volume status, the nephrotoxicity, the inflammation are all kind of playing a role, and probably some of these other features like the cardiac involvement, et cetera, are probably not involved. Patients who start out with either mild AKI or no AKI who gradually develop worsening renal function, then you get more and more concerned about some of these extra pulmonary manifestations of COVID playing a role in the kidney. And I think the management strategy becomes very different. So early on, I think that you should be cautious with the use of things like diuretics in these patients, even though, we've become very accustomed to treating ARDS, with diuretics. These are not patients who often receive a lot of fluid resuscitation early on, and therefore low urine output is usually not indicative of volume overload and renal dysfunction. It tends to be more of a problem with dehydration. So we want to be careful we don't make things worse with diuretics. The other thing that can happen in a volume depleted patient is if they receive PEEP, particularly more than about 10 centimeters of PEEP, they may get over PEEPed, and particularly in a compliant lung situation, over PEEPing of the patient may result in decreased venous return and further complicating the kidney perfusion. So I think there are, and that's, I think, somewhat unusual, certainly for ARDS, and it makes the COVID patient a bit different. They're a bit more vulnerable to overpeeping, and they're a bit more vulnerable to dehydration when they present. I think that the kind of AKI that happens later, particularly if it's in the setting of multi-organ system failure, has an incredibly bad prognosis. And I think that, like in other forms of multi-organ system failure that have a bad prognosis, it is an opportunity to think about, even before you get in any concerns about rationing or anything else, as to whether renal replacement therapy is even an appropriate consideration, is in the patient's best interest, if it's happening certainly in the setting of a low ejection fraction and a very sick patient. So I think all of those things are really make up the approach to AKI in these patients.
Yeah, we've discussed triage scenarios as well, and just the complexity regarding how do you triage limited supplies and the like. I think I'm in danger of going down a doctor-to-doctor rabbit hole right now, so I'll just back up and say, any general other thoughts you'd like to say, Dr. Kellum?
I think we covered. I think we covered all of the real important points that we set out to. I would sort of summarize by saying that I think it's vital, both for management and planning, that people really understand their AKI rates and what's driving it at their hospital, and address it based on the problems that they're seeing and the vulnerabilities they have, whether it's staffing or machines or other supplies, because I think the strategies, as you've heard, are a bit different depending on where the vulnerabilities are.
Great. Jason?
Thank you. We have a slide that summarizes all the points that we've been through. Dr. Kellum, looking at that again, is there anything else you would like to say?
No, I think we've covered this very well. I think maybe the only thing we didn't discuss was whether we would recommend, as part of the planning strategies, transfer of patients. And I think that's a complex issue based on a variety of logistical factors. And it may be easier, for example, to transport equipment or personnel than it is necessarily to transport a lot of COVID patients. So thinking through some of those things for the local hospital and the situation on the ground, I think is vital.
Thank you very much, Dr. Kellum. We'll now move into our Q&A section. Please use the Zoom's Q&A function to type in any questions you may have. While they're coming in, I'll tell you what our polling results showed us. We're seeing 44% of you said that you are seeing an increased demand in renal therapy in the ICU. And kind of paralleling what our own data said, about 20%, just short of 20% of people are reporting supply shortages. So, and 39% said no, and 43% said, I do not know. So without further ado, we'll move on to questions, which I will read out here for you. With the increased concerns of hypocoagulability in COVID-19, are you observing the use of heparin infusion pre-filter for CRRT? And if yes, what doses are used considering the potential for systemic circulation? Dr.
Yeah, so that's a great question. And yes, many centers have reported hypercoagulability, not only in the patient, but also in the dialysis circuit. The strategy for that is multi-pronged, I think. So I think the first thing is to just go back to basics. A lot of places are still maybe not using as high a blood flow rate as they should be. And so low blood flow rates will prompt clotting more than high blood flow rates. So trying to get the blood flow rates up to 250 or so if you can, which requires good access. I would also say that if I had a choice as to where to put the access, I would use the IJ both for the internal jugular, both for good flows to maintain those high blood flows, but also because prone positioning is something we have to do in a lot of these patients. And it just gets more complicated when there's catheters in the groin and trying to deal with all of that. It's best to have everything on top. So I would use the right IJ as my first choice, left IJ as my second, and use high blood flow rates. In terms of anticoagulation, yes, many programs can get by with their routine renal replacement therapy patients without requirement for anticoagulation. And COVID seems to be different. And so using a full dose anticoagulation of the circuit, as well as sometimes the patient for this. And I've even heard, although we've not done this, I've even heard some centers using even a combination of regional citrate anticoagulation and still anticoagulating the patient as well. Now, one thing I would point out is that patient that has this severe hypercoagulable state is having very high D-dimer levels, is clotting the circuit left and right. Those patients often have systemic hypercoagulability and are developing DVTs and pulmonary emboli. Many of us are anticoagulating those patients with full dose anticoagulation. I've had patients break through very high dose Lovenox, for example, and still required going on full dose anticoagulation, monitored by factor 10A as we would for a PE. And I think you really have to consider a patient who's that hard to anticoagulate on the filter as having systemic thrombosis as well. And so I think that your strategy is going to be dependent on not only the circuit, but what's happening to the patient. So thank you for that question. It's a very big problem, even in young patients with COVID-19.
Thank you. The next question is fairly similar. How have you managed patients on pre-filter extracorporeal heparin infusion for CRRT access issues who also require systemic IV heparin for acute DVT or PE?
Yeah, that's sort of, Andy, that's sort of what I was alluding to a moment ago. I think the strategy has to involve what you're doing for the patient as well as what you're doing for the circuit, because they tend to go hand in hand. That patient who's clotting a filter, every 3 hours is probably developing DVTs, is probably at really high risk for pulmonary emboli, et cetera, et cetera. And so we tend to, and we monitor D-dimers in these patients where they can be extraordinarily high. And we're putting a lot of these patients on full dose anticoagulation, not for the circuit, but for them. And so if we're treating the patient, with full dose unfractionated heparin as we would in a treatment strategy for pulmonary emboli, then obviously we're not doing anything extra for the device in terms of heparin, but we are maintaining high blood flows. We are, in some cases, people are still using regional citrate anticoagulation, even on top of full systemic heparinization, if you can imagine that. And that's several centers have reported that. So I think it's not an isolated phenomenon.
Thank you. Next question is a spelling bee type question. Can you spell the cytokine storm syndrome that was discussed? They missed the syndrome's name. Is it the Kawasaki?
Yes, so there's a couple of different names that this goes by. Atypical HLH, and don't ask me exactly histo whatever it is, and then macrophage activation syndrome, which is MAS. And both of those terms are synonymous in terms of, there's a little bit of difference as you get into juvenile rheumatoid arthritis, which is another cause of this syndrome. But for this kind of viral disease in adults, the term macrophage activation syndrome and atypical HLH are synonymous.
Thank you. Have you seen the use of APD therapy in acute patients when CRRT supply or ability becomes exhausted?
I have not, so I don't have any personal experience with that, and probably should leave it there. I have heard that has been, particularly in London and some other centers where that has been an issue.
Thank you. And the last question is more a supply issue on the machines. A question came asking whether we're seeing any shortages of dialysis machines and longer lead times. We will have to answer that offline. I don't believe any of us will have the answer for that here. But in the meantime, that concludes the questions that we've received. I'd like to thank Dr. Kellum, especially for joining us today and sharing his expertise. It's been, we've learned a lot. And for my other colleagues, Dr. Furman and Tim, thank you for joining us today. And thank you all for joining us. And I hope you learned something. Next week, we will be addressing the use of ultrasound in the age of COVID-19. Not just for COVID-19 patients, but we're shifting into the new normal and caring for all types of patients. And we will have more experts here, and we will actually have ultrasound machines to demonstrate on. So we hope to have you tune in next week. Thank you very much.